Good evening, everyone. At the very outset, I would like to thank Inovocare E-Academy for hosting this 7-day event to observe the National Pharmacovigilance Week under the aegis of Pharmacovigilance Programme of India, Indian Pharmacopoeia Commission, Ghaziabad, under Ministry of Health and Family Welfare, Government of India. IPC is today in its 10th year of inception and has significantly contributed in the world map of patient safety. With around 300 ADR monitoring centers nationwide, IPC has established a framework of coordinated patient safety surveillance, which is in constant liaising with over hundreds of medical colleges, involving thousands of physicians nationwide for the spontaneous ADR reporting. Drug allergies as a subset of the ADRs make a significant public health concern, complicating 5 to around 15% of therapeutic drug courses, leading to a diminished quality of life, increased physician visits, hospitalization rates, and even death. In a third day of this series event, we are looking forward to have an interesting conversation on management of drug allergy. Myself, Shatavisa Mukherjee, Pharmacovigilance Associate at ADR Monitoring Center, School of Tropical Medicine, Kolkata, will be moderating today's panel event, which is in collaboration with Allergy and Asthma Research Center, Kolkata. I would like to thank and welcome all our revered panelists for joining us this evening. We are joined here by renowned dermatologist, Professor Dr. Nilay Das sir, who is affiliated to Bankura Shammilani Medical College, having numerous publications and awards to his credit in recognition of his contribution to the discipline. Thank you, sir, for joining us.
Thank you so much.
Next, we are joined by Professor Dr. Saibal Moitra, sir, an eminent pulmonologist in town and an adjunct professor in the Department of Allergy and Immunology, Apollo Gleneagles Hospital, Kolkata. Thank you, sir, for joining us today.
Thank you.
Next, we are joined by Dr. Aratrika Das, senior pulmonologist and allergy specialist practicing in Kolkata. She is an alumnus of KEM Hospital, Mumbai, and has various publications to her credit. Thank you, ma'am, for being with us. Last, but definitely not the least, we are joined by Dr. Shambo Samrat Samajdar, who is a consultant at Diabetes and Allergy Asthma Therapeutics Clinic, Kolkata, and is currently affiliated as senior resident at Department of Clinical and Experimental Pharmacology, School of Tropical Medicine, Kolkata. Thank you, Dr. Shambo, for joining us.
Thank you.
Today's session will be chaired by our most revered teacher and renowned clinical pharmacologist, Professor Dr. Santanu Tripathi, sir, who needs no separate introduction. Professor Tripathi, sir, is one of the pillars of pharmacovigilance system in our country. He is currently the Dean Academics and Head of the Department of Pharmacology, Netaji Subhas Medical College and Hospital, Bihta, Patna, and also the coordinator of the AMC at NSMCH, Patna. We are honored to have your insights with us, sir, today. Without wasting any more time, let's start today's discussion. I would request our attendees to place their questions in the chat box during the session. So as we know, drug hypersensitivity reactions are clinically and functionally heterogeneous. Different subclassifications based on the timing of the symptom, appearance, or type of immune mechanisms have been proposed. Our first question to Dr. Shambo to kindly share his insights on mechanistic classifications of DHR, that's drug hypersensitivity syndrome. Over to you, Dr. Shambo.
Thank you, Shatavisa, for this important question, because while talking about drug allergy, it is very important to understand the Jell-Coombs classification, because that gives some idea how we should proceed for each cases. So as we all know that generally drug allergy can be divided into 4 broad groups, type 1 to type 4 hypersensitivity reactions. And generally the type 1 hypersensitivity reactions, that what we know, that is IgE mediated reactions. So what happened in the mast cells, the IgE receptors are occupied by IgE antibodies, and then when one antigen or allergen or some in this case drug, enters into our body, that is coupled by two Ig antibody, and that causes some changes in that particular mast cell and release of histamine and other mediators. So this is one type of immediate type of hypersensitivity reactions, and many other diseases, allergic disease that we know, like asthma or allergic rhinitis or urticaria, specifically the Ig mediated urticaria, they all are coming under this category, type 1 hypersensitivity reactions. Then when talking about type 2 hypersensitivity reaction, that generally occurs at the level of the cell, and what happened in the outside coating of the cell is occupied by antigen. For an example, if we can talk here antigen as a drug like penicillin, so penicillin take the position as a antigen and coated the cell. And what happened to that particular RBC cell, if we consider RBC as a cellular things here, so IgG antibody attached with that particular antigen, that means penicillin, and that provokes different types of immune cells, starting from natural killer cells or complements, or sometimes there are specific types of opsonization also happen. So either there will be killing of target cells by natural killer cells or macrophage due to that IgG occupancy of that particular antigen portion, or that will stimulate complement system, which causes complement mediated lysis, and ultimately the RBC will be damaged, and we know there will be penicillin induced hemolytic anemia will be occurred. Next, another area is that type 3 hypersensitivity reactions, and which we know when the times of anti-diphtheria antitoxins appears, and now the cases of diphtheria goes down, we don't see this type of reactions, that Arthas reactions. But this is a very important concept again. And what happened, the IgG antibody here, they binds with IgM antibody, and along with that they take the help of the complement systems, and they produce one complex, and that complex will deposit in specific tissues, and that causes a specific activation of Fc gamma cells, because here the IgG is the main culprit, and they causes local inflammation, phagocytosis. One very important disease we know that SLE generally follow these type 3 hypersensitivity reactions. And ultimately coming to the type 4 hypersensitivity reactions, which is a delayed hypersensitivity reaction, there is the role of T cells a very important. And what happened, the particular antigen presenting cell presents antigen to T helper cells, and then the T helper cells ultimately release the signal 3, and that signal 3, depending on the which type of cytokines they are releasing, the particular T helper cells starting from Th1 to Th2, they will differentiate into those, and there will be ultimately activation of the macrophage and different types of cytokines like interferon gamma, maybe TNF beta. So maximum cases of type 4 hypersensitivity reactions that we see, they are like DRACE, or we can say Stevens-Johnson syndrome, or some in historic cases we may say the poison ivy mediated reactions. So these all are examples of type 4 hypersensitivity reactions, and we all know that tuberculin test, that is a classical example of type 4 hypersensitivity reactions. But as I started with type 1 hypersensitivity reactions and only talking about mast cells, there I just want to give emphasis on another area, another important point, that is even the type 1 hypersensitivity reaction, we are talking about mast cell mediated reaction, but the key player here also is the T cell. because T cell will ultimately teach the B cell to produce Ig, and after that Ig production, which attached with that particular epsilon receptor over the mast cell, when the second times that particular drug or antigen enters, that will be coupled by that Ig antibodies. So here also in the type 1 hypersensitivity reactions, sometimes we forget to mention about this T cell and its importance, but I just want to give again emphasize on here that T cell is the master player or key player even in the case of type 1 hypersensitivity reaction. With that, I think this is the main different types of mechanism that you have asked. Over to you.
Thank you, Dr. Shambo. Our next question to Professor Nilay Das, sir. So we would like to know your viewpoints on diagnostic and management approaches on severe cutaneous areas. Speaking of type 4 hypersensitivity, as we thought. Over to you, sir.
Thank you, Doctor. Thank you so much. Before I go into that, I want to just bring into light one important thing which I think Dr. Shambo has highlighted regarding mast cell degranulation. Of course, immunological degranulation is an important aspect of mast cells cutaneous adverse drug reaction, and what we get drug-induced urticaria. Apart from that, with certain drugs like codeine, like morphine, there is instances of direct degranulation without involvement of immunological system. So direct degranulation that can happen even without any pre-sensitized host. So that is one thing apart from the immunological mechanism which Dr. Shambo has so elaborately told us. Now regarding the severe cutaneous drug reactions, we have mainly 4 forms which has got the highest mortality. Then of course DRESS or drug hypersensitivity syndrome, which Dr. Shambo has highlighted. Apart from that, we have got AGEP, acute generalized exanthematous pustulosis, which has got a mortality of almost ranging like 10%, and of course erythroderma. So when we are dealing with the severe cutaneous drug reaction, or otherwise known as SCAR, we highlight into 3 or rather 4 such entities. When we have to manage, of course, while we are dealing with drug rash and cutaneous adverse drug reaction, the first and foremost is stop all suspected culprit drug. So there can be the causality association, which can give us an idea like which are 1 or 2 or 3 causality suspected agents. And we at the most time, clinically speaking, that we find because of polypharmacy, when a patients come to us, especially with such a cutaneous adverse drug reaction, there are almost like 4 or 5 drugs which are being given. So first thing is stop all suspected drugs. Then these 3 or 4 severe cutaneous drug reactions leads to what we call it skin failure. Skin failure means the skin which has got some primary function starts failing, which include prevention of infection, which includes electrolyte balances, which include thermoregulations. So we have to ensure that these supportive measures are given in the form of maintaining a aseptic environment and give them barrier nursing, provide fluid electrolyte balance, because most of the cases we lose while we are dealing with severe cutaneous adverse drug reaction is because of the electrolyte disbalance. So it is very important. Another important aspect regarding the management of severe adverse cutaneous reaction is maintaining thermoregulation. So when a person is being admitted in HDU, and when we all know when we visit HDU, the temperature is really chilling. And that chilling temperature is a killing temperature for all those patients. So if you have to get the patient admitted to HDU or ICCU, please make sure the temperature is up to the extent of at least 20 of hypothermia. So these 4 parameters are the general measures which we have to follow. As a matter of fact, many of the studies have shown with these supportive measures only, the patients recuperate. If you withdraw the drug, if you provide supportive care, the patients withdraw. Now comes the question, I think you are interested in specific pharmacotherapy. There were days when we were resident and we were relying on systemic corticosteroids. Now with passing time, there are accumulative evidences that systemic corticosteroids are not of much value. There are many meta-analysis which has shown that systemic corticosteroid can damage more than it can do the benefit. So we are moving away by not giving systemic corticosteroid, but moving to another important agent in our armamentarium is cyclosporin. I think Dr. Shambo has told us about the type 4 hypersensitivity and the cytokines which are being involved. And another important agent in SJS10 syndrome is granulysin. This granulysin and perforins, they are important markers which for SJS10. And cyclosporin is one of the agents which has shown to reduce granulysin. So nowadays, and we in our institute have performed record-based study, and which where we have found definitely that by using cyclosporin, we can reduce the standardized mortality rate as against supportive therapy, as against corticosteroid. So steroids into cyclosporin in toxic epidermal necrolysis, in DHS or drug hypersensitivity syndrome or DRESS, even in erythroderma. AGEP is not having much of a mortality. It resolves very quickly if it is like the drug is withdrawn. So we really don't go for immunosuppressive in case of acute generalized exanthematous pustulosis. So this is just in a nutshell, but of course there are important things to be understood, that these severe cutaneous drug reactions are not just having cutaneous effect. They have systemic manifestations too. So apart from managing the skin, one has to look forward for other systemic involvement, including respiratory system, including GI system, cardiac system. So this is a holistic approach. It's not that the dermatologist is going to manage it. It's rather the internist who manage a severe cutaneous drug reaction.
Okay, sir. So another question to you. So are there any long-term complications of SJS and 10?
Absolutely, absolutely. I think I have told you that SJS10 is not a disease which involves the integument. SJS10 involves respiratory system. There are evidences where there are evidences of interstitial lung diseases following SJS10. There are instances where there is carditis. Long-term complication, of course, since SJS10 involves the mucosae, and if there is synechiae of the eyelid, and there are instances where there is blindness, it involves the GI system, and GI system involvement can lead to, and it has been found in many of the studies that this GI system involvement can lead to malabsorption in the later scenario. So SJS10 has got long-term complications, and of course we have to judge by the extent of its systemic involvement, apart from the dyspigmentation, the change in color that we find in the skin. One important thing regarding drug hypersensitivity syndrome, the DRESS. Now, DRESS is very interesting. Even if you withdraw the drug and the patient has recovered, DRESS is one condition which can show relapse without giving any other drug for the next 6 months. So, interestingly, this is important that the patient should be counseled. The patient may have recovered, and we always ask, don't take these drugs which are suspected. Even then, even by stopping the drug, that same patient can develop and relapse with the same symptoms for the next 6 months. So counseling is very important. And one thing which Dr. Shambo has not highlighted is that in case of DRESS, not only is the drug that is important, there are evidences where viral infections are also being incriminated. So antiviral agents are also being used in case of DRESS. So one of them is HHV6 and HHV7. So these are important aspects which are coming up. And I think this is a very close-knit immunological and infectious disease which closely perform its assault on the skin and the different organs.
Thank you, sir. Thank you, sir. Dr. Shambo, you had any
Yeah,
question?
can I make one comment? Yeah. So actually, Sir has beautifully mentioned about that morphine-related reactions, and that is a drawback of Jail-Coombs classification. They not include the pseudo-allergy, and actually, we need to understand that pseudo-allergy is completely a separate chapter, and it is very important to understand because sometimes we should not miss this and misdiagnose it with type 1 hypersensitivity reaction, because the characters of pseudo allergy is almost equal with this type 1 hypersensitivity reaction. So it is an immediate systemic reaction and same like anaphylaxis, but we should remember this is not triggered by IgE, and other symptoms like starting from bronchospasms, urticaria, angioedema, even rhinitis, same like type 1 hypersensitivity reactions. And the treatment is also almost same. There is nothing different. But if we not identify the pseudoallergic reactions, what is important, because in case of type 1 hypersensitivity reaction, we can desensitize patient. But in case of pseudoallergic disease, we cannot desensitize patient because the mechanism is maybe complement mediated, maybe mast cell directly related. The drugs directly activate mast cells, or sometimes stimulations by these exogenous molecules to different immune cells, like maybe some drugs stimulates the phospholipase D activity. There are some confusions in us that COVID-19 vaccine, there are some excipients called as polysorbate. They are very allergic sometimes. So they have similar type of mechanism, this polysorbate 80. They just stimulates phospholipase D activity. And other drugs like already sir has mentioned about morphine, codeine, aspirin has this property. Previously, this same type reactions also known as anaphylactoid reaction, but now it is named as a pseudo allergy. So this is a very important, interesting area, and we should have some focused discussion also on this. So this is the thing I just want to add. Over to you.
Thank you, Dr. Shambo. With this, we would like to come to another important topic of antibiotic allergy. With beta-lactams being one of the most commonly prescribed antibiotic and one of the most common causes of drug hypersensitivity reactions, our very next question to Professor Moitra, sir. So we would like to know your viewpoints on antibiotic allergy, its management approaches, and a need for specific testing guidelines in countries like India. Over to you, sir.
Yeah. Thank you, Shatavisa. As you have rightly said, that antibiotic allergy is a problem which needs to be addressed and properly addressed. Okay. You see, in a clinical practice, what we see in most of the times, if you take a history, you might find that the patients are often incorrectly labeled having a penicillin allergy. So they might give some history that they had taken some medicines, maybe amoxicillin or something, and they have some symptoms, and these patients are labeled as penicillin allergy. So then we go in, and that label stays with the patient. That label stays with the patient till the patient dies. So whenever a patient goes to any doctor, the patient, he or she will say that I have penicillin allergy, and the label stays. And that really is an important factor, because we need to delabel the patient and label the patient correctly. So penicillin delabeling is a very important thing which we need to say, because see, drug allergy means it's a time consuming and very meticulous history taking, which in our case, in our country, most of the time we fail to address that. It's very, very important. It is more difficult in our patients because we need to sit with the patients, take a detailed history of what are the medicine patient has taken. As Dr. Dash and Dr. Samajdar was saying, that polypharmacy is very common in our country. All the medicines are available over the counter. So that means the patient goes and takes any medicines. multiple medications patients take, and they land up into some kind of the allergic symptoms, which may be because of the drug, which may be because of something else also, maybe because of some viral infections which has triggered the drug allergy. So it is a most important cornerstone of making a diagnosis is taking a meticulous history, incorporating all the drugs that the patient might have taken. If possible, the patient has the prescriptions, that helps a lot. Otherwise, we need to be a detective in this front. So history taking is the most important cornerstone. And first of all, identifying that what are the drugs the patient could have taken. And then we have the list, we know that which are the molecules which can cross-react. As we know that all the penicillin group of drugs, maybe the penicillins, cephalosporins, they all have a beta-lactam chain. And so they're all beta-lactams. But it is not true that the patient might be, that beta-lactam may not be the epitope. The epitope maybe, that means that is the molecule which is actually activating a particular antibody, the immune system. It could be some side chain of that beta-lactam also. So often, if a patient maybe is having an allergy to a beta-lactam, say penicillin, the patient may not react to cephalosporins, or the patient may not react to a monobactam. Okay, so this is very important. We need to understand what are the patient's medicine have taken, and then correlate with, we need to find out that what are the other medications which share the similar type of chemical structure with that agent. Next comes the testing. So as Dr. Shambo has so nicely pointed out, see, when we are testing a drug allergy or a drug hypersensitive reaction, what modalities we have in our hand. We know that the type 1 hypersensitive reaction can be tested by a typical wheel and flare response, which could be brought about by a skin prick test or an intradermal test. So only those drugs which is causing this allergic reaction by a type 1 hypersensitive reaction involving the IgE and the mast cells, they can be diagnosed by a skin prick test and an intradermal test. Okay, but at the same time, which is another factor which is very important, is the concentration of the drug which would be used for testing that particular drug. One is known as a non-irritant concentration of the drug. It should be the direct irritant effect of the drug can also cause the mast cell degranulation. So we need to have the non-irritant concentration of the drug, and that concentration should be used for testing in skin prick or intradermal test. We have a list which is available freely in the net. So what is the non-irritant concentrations of the various drugs? But unfortunately, we don't have the non-irritant concentration of all the drugs. So that means for those drugs for which we don't have, we cannot test them because it might yield a false positive result. Number two is that those drugs which causes a direct activation of the mast cells. Okay, these drugs may not be acting via the IgE, a high affinity IgE receptor and the IgE. They might cause direct activation of the mast cells. Mast cells are studded with numerous receptors. One of the receptor which is coming in forefront these days is the MRGPRX2. And this MRGPRX2 receptor and its polymorphism, this receptor can also degranulate the mast cell, but here the drug can directly act to the MRGPRX2. Okay, so now we have MRGPRX2 polymorphisms. It can cause an individual more susceptible to certain drug allergies. So what happens is that if a drug can activate the MRGPRX2, so that means it is not acting via the IgE, but even if you give that drug in the skin, that might cause some degranulation over there. These kind of reactions we specifically see in case of fluoroquinolones. Though this codeine and opioids have been shown to act via MRGPRX2, but since we do not have the non-irritant concentration of the codeine, which can be used for testing via the MRGPRX2, so there comes the problem of it testing on the skin. At the same time, we have the fluoroquinolones. So these are the various important drawbacks or various important hurdles which we have to keep in our mind while we are testing for a drug allergy via skin prick test. So even if the patient may be having some allergies and they don't come out with positive skin prick test does not mean the patient is not allergic to it. So the best test that we do, and though that cannot be done in those patients with the severe reactions, in them we should not do it, is the graded drug challenge. So graded drug challenge is another modality of testing. It could be antibiotics, it could be any other, but we have the protocol for the graded drug challenge, not for all the medicines, but for few antibiotics, we have the protocol for the graded drug challenge testing. For the graded drug challenge, what happens is that when a drug is given in the graded concentrations over a period of time, and the patients have to stay in the clinic or in the hospital. Basically, it is carried out in a hospital setup where you have all the facilities is for resuscitating the patient if any severe reaction occurs. In that setup, the graded drug challenge usually yields, if it gives a positive result, it could be by any of the mechanisms. So that actually is an important and helpful part in the graded drug challenge. So we have, one is the main is the history taking. Apart from that, for few drugs, we can do a skin prick or an intradermal test. And for some drugs, we can do a graded drug challenge. So these are only the modalities which we have for testing a suspected drug allergy. But again, I would say at the end, it is the history taking which is the most important. For some drugs which has actually caused a very severe reaction, we usually don't intend to do a challenge testing with those drugs because it is contraindicated in those cases. And apart from it, while we are dealing with a drug allergy condition, we need to rule out some underlying other conditions which usually manifest as a drug allergic reactions, as we know that it could be a mast cell activation syndrome or systemic mastocytosis. I think if some questions arises, we can discuss on that later.
Thank you, sir. Do we have Dr. Aratrika Das ma'am with us? I don't see her in the panel. Rohan, can you confirm? Do we have Dr. Aratrika ma'am with us?
She was having problem with the
may I put
connectivity.
One of my input.
Okay.
Dr. Shatavisa, just one input, as very nicely been put forward by Dr. Moitra, that skin prick test can only highlight on the type 1 hypersensitivity. And recently, we means dermatologist, we have somewhat, we have not standardized yet. It's very nascent stage. We have started using patch test to find out the delay or the adverse cutaneous drug reactions are type 4 hypersensitivity, and skin prick test is no way going to give you any idea about that. So patch test in the concentration of 10% and 30% of the drug is maybe used on breached skin. The skin is to be some that you put to remove the stratum corneum, so that's so as to allow the drug to get inside. And so this is one of the important parameters which is coming up and used, and it has been found to be useful in drug hypersensitivity syndrome or DRESS, but not much in SJS10. But we also have to understand that SJS and DRESS can even be provoked even by using a patch test. So one has to do the patch test, as Dr. Moitra has rightly said, under strict supervision. We cannot just ask the patient to apply the patch and go home. So these are to be used as an institutional setting. But this is something new that has come up. Thank you so much.
Thank you, sir. We would take up a question from our chat box. Do really the traditional skin test or RAST have any conclusive role in penicillin allergy? Over to you, Moitra, sir.
Okay. See, number one, we need to understand few of the basic mechanisms of the penicillin allergies. As I've said, one of the mechanism would be antibody as the IgE mediated. But the penicillin allergies could be a non-IgE mediated reactions also. We have we have the PI concept. We have some invariant T cell which can get activated by the penicilloyl moiety, and it can cause activation of the other cellular mechanisms. and leading on to the effector cell functions, and which can ultimately lead on to a clinical condition, the drug allergies. So these are the conditions in where we cannot detect it by a traditional skin prick or an intradermal test. So again, this traditional skin prick and intradermal test is only for the immediate hypersensitivity reactions and not for any other mechanisms. As for the RAST, RAST has more or less gone into disrepute. We don't use RAST. RAST only detects the specific IgE, so which is nowadays can be detected by the Immunocap, which is a standard technique, but we don't have a very standardized Immunocap technique for the drug allergies. Because as I've said, for the penicillin allergy, it may be IgE mediated, it may not be IgE mediated. So either after taking a very good history, the next thing is that using a non-irritant, another very important aspect of doing this, the penicillin allergy test, is that the penicillin oil moiety, which is the major epitope in case of the penicillin allergy, it is not available for testing in our country. So penicillin oil moiety is not available. Apart from that, usually using the traditional penicillins or the penicillin, like the benzyl penicillin or the amoxicillin, it is not as good an alternative of the penicillin oil lysine, and which is actually the agent which has to be used for testing of the penicillin immediate hypersensitivity, either by skin prick or the intradermal test. So, but in place of not having any other alternative, we have to use that in our country, as long as it doesn't get available in our country, maybe in next few years. So that is the thing, is that RAST and the skin prick test or the this specific or the intradermal test, they can only detect a specific part of the penicillin allergy. But the hurdles are 2-3 things. One is non-availability of the penicillin oil lysine moiety. Second is that we don't have a standardized Immunocap for the penicillin testing. Third is that the non-IgE mediated mechanism of the penicillin allergy cannot be tested by the skin prick test. But one good thing we have is that we have the non-irritant concentration of the penicillin oil lysine moiety, that we know. We have the non-irritant concentration of the amoxicillin, and that we know. So these are usually the things which can be used. But for the other mechanisms, this is not the test. So even if a patient gives a history of penicillin allergy, to document it, if you don't get this testing right, the only thing, if it is not a serious drug allergy, what you can do is you can go in for a graded drug challenge. That is an alternative.
Thank you, sir. Taking up another question from our chat box, we have Dr. Sean has a question. Can topical steroids cause acne? If so, what is the mechanism? Over to you, Dr. Nilay.
Of course, it can cause. Topical or systemic or any sort of steroid can cause acne. The mechanism are multifactorial. As we call for comedogenic, this follicular hyperkeratinization is an important aspect where the where the sebaceous gland outlet is being blocked. Apart from that, steroids causes the hormonal changes, which causes seborrhea. So these are the important things. So topical or systemic steroids are liable to cause acne. And as we have seen in the treatment of COVID, so many patients who have been treated in ICU with steroids, they developed acne. But this is something which Dr. Moitra has highlighted. This is a non-serious adverse cutaneous reaction. So we are not really worried about those acne which occurs due to systemic steroids. But of course, topical steroid is a strict no, and we always have found that topical steroid is being misused as a fairness cream, and it is a over-the-counter medication. So we have to be extremely careful. Our association has been extremely vigilant, and we have been highlighting in various forums. Please do not use this topical corticosteroid as a fairness cream. And if you don't know what you have to use, then don't please use steroids, because steroid is going to modify whatever you're getting. It can modify a tinea incognito, modify a scabies incognito. So if you don't know what to use, please don't use steroids. Another important thing, this acne form eruption always also can occur apart from steroid by tyrosine kinase inhibitor. So if you get acneiform eruption, you have to be careful not only of steroids, but also of new things, tyrosine kinase inhibitor. Antidepressants, lithium have the propensity to trigger acne. So acne can be triggered not only by steroids, but also by lithium, as also by rifampicin and isoniazid as an anti-tubercular drug. As you might be seeing, those patients receiving ATDs will develop into acne. So apart from steroids, please do remember it's not always the steroid which causes acne, but there are other drugs which has got the potential to. I think so I'm over.
Thank you, sir. Over to you, Dr. Shambo.
Can I make one comment?
Yeah, sure.
Yeah. So as sir has mentioned about that topical corticosteroid, there is another important area. There are some patients, some case reports on immediate type of hypersensitivity reaction with depot steroid injection. And to search the cause, then it was found that one of the very important excipient present in the depot steroid injection is polyethylene glycol. So this is another important thing we should consider. If a patient presents with type 1 hypersensitivity reactions with depot steroids, we should search for the culprit. It may be the excipient, which is known as polyethylene glycol. We should not just blanketly stamp depot steroid as a positive agent for type 1 hypersensitivity reaction. So this is just I want to add on.
Thank you. As a consultant in this clinic, I would like to know your views on insulin allergy, the various diagnostic and management dilemmas concerning it.
Hello.
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 Yeah, you are asking me about that insulin allergy, na?
Yes.
Yeah. So yeah, this is an again important, very important topic, because though this is very rare, maybe 1% of our insulin patient may experience with this type of insulin allergy. But if it happens, then the important thing is to identify the type of allergy, type of hypersensitivity reactions. So whether it is type 1 or Ig mediated reaction, or it is other types, most commonly it is among the non-Ig mediated reactions, it is generally type 4 hypersensitivity reaction, and some instances, some case reports on type 3 hypersensitivity reactions on insulin also we found in literature. But the thing is that how we can identify, as Moitra sir has beautifully described, how to identify type 1 hypersensitivity reactions with penicillin. Here also the protocol is same. We can do skin prick test or intracutaneous test, and we can identify whether the patient has IgE mediated reaction. So what is important here also, to give emphasis on the excipients, because excipient allergy is often seen in patients with insulin allergy. So without going in details to see whether the patient has excipient allergy or not, we should not just de-challenge insulin in that particular patient. There are different types of insulin nowadays, different analog insulins we have. If we go by the excipients list of that particular different insulins, we will find that some insulin has protamine, some does not have. Just giving one example, if a patient that was also reported in a literature, it was a Humalog insulin, we all know that this is a Lispro insulin, which contains both zinc, protamine, and also cresol. So that particular patient present with a typical type of hypersensitivity reaction, and now came to that particular the doctor, and it was found that she has protamine allergy. Now, in case of glargine insulin that is present as Lantus, it does not contain protamine. So they in glargine, zinc and cresol is present. So they just de-challenge or de-prescribe Humalog and give glargine insulin along with some short-acting insulin like human regular insulin, which also does not contain zinc and protamine. So what happened, that allergy was not there. So this is the thing in patients who are presenting with insulin allergy, because in case of type 1 diabetes, we cannot de-prescribe insulin. We need to give insulin. So there, we should find some answer. And for that, we need to go in details about that particular excipient list. And after that, we can decide. But in case of type 4 hypersensitivity reactions with insulin, or sometimes type 3 hypersensitivity reactions, if it is severe, then there is no way we should de-prescribe insulin. We need to give emphasis on other process, other therapeutics, maybe oral anti-diabetes agents, or sometimes maybe GLP-1 RA. So we have no answer for type 3, type 4 hypersensitivity, severe type 3, type 4 hypersensitivity reactions to insulin till date, except that de-prescribing insulin. But mild case of type 4 hypersensitivity reaction means just itching, or sometimes after taking insulin, they may present with nausea and diarrhea. So in that case, if there is no other option to switch from other drugs, we can use symptomatic management. We can use antihistamine or other drugs. So this is in a nutshell how we can approach one patients with insulin allergy.
Yes. Another thing. Hello.
Yes, sir. Yes, sir. We can hear. Hello.
Yeah. Okay. And one thing that I would like to add, that Dr. Shambo, you so nicely you had stated this thing. And what happens is that insulin allergy, that was the main idea. There is, as we all know, that in the basic mechanism of a drug becoming an allergen, it depends upon, in one concept is the haptenization. Okay. So that means that the drug itself does not cross that molecular weight threshold, which will be actually recognized by the immune system. So what happens is that that drug, though there are now the other concepts which has come into, which we can discuss for some other drugs which does not need haptenization. But for insulin, you can say that these drugs has to be bound to some circulating proteins. Okay. So insulin being quite a means, and the molecular weight being quite high. So this thing was kept in mind that this may not need a haptenization to actually activate the immune system. So this is an important concept, that insulin allergy can occur in spite of not having an haptenization, and its fallout in the diagnosis of the insulin allergy lies in the fact that if there is some structural changes or some changes, modification in the molecular structures, which can actually cause some insulin, having different types of allergenic management. Not, I won't say allergenic. Allergy is not the right word to be used, because they can be having the other hypersensitivity mechanisms and other mechanisms for causing adverse drug reactions, which is a better word to be used for this.
What is the scope for desensitization in case of insulin allergy? people have
Sir,
tried,
in-
I think,
Yes, sir.
desensitization.
In case of if it is type 1 hypersensitivity reaction or IG mediated type 1 hypersensitivity reaction, there is obvious we can do insulin desensitization. There is some protocol also. There are some case reports also where we can find that protocol.
How to do the trade-off between the hyperglycemia and when you do the desensitization, okay, naturally the insulin requirement is not being met. Then how to otherwise manage the hyperglycemic state, and so
Yeah.
this
So
is
there
a
is another
challenge.
important
It's a challenge.
concept, sir. There is another important concept in case of insulin allergy, as you had rightly mentioned, sir. If we can use continuous subcutaneous insulin infusion, there are insulin pump are there. So as insulin is giving continuously, so that process also can cause desensitization, and that is also tried in some setting to see how they act, and it is found helpful.
Yes, this is a good observation, but it becomes very difficult to actually substantiate that continuous subcutaneous infusion by pump mechanism, one can easily desensitize, and there has been a lot of success in many series of patients, that many people have tried it and it has worked. But how to actually explain if it is IgE mediated, and then while the traditional insulin dosing regime is causing allergy, but when you switch to insulin pump, then the allergic manifestations are otherwise taken care of. It's not manifest that way. So there is a problem in properly explaining how it is happening, mechanistic explanation.
Yeah, I think Moitra sir can give more elaborately these mechanisms. But what I think is that the mechanism is same like what we do in case of allergen immunotherapy. So we know the principles of allergen immunotherapy. We need to give that particular allergen in low dose and then gradually go up. And by that way, what happened ultimately, that Th2 response, which is the pathognomonic features of all type 1 hypersensitivity reactions. So in our body, the Th2 response now converted into Th1 response. So that typical class switching that generally happens between IgG to IgE, that will not occur if we can have that procedure. Maybe this is an hypothetical answer. May I ask Moitra sir for his expert comment?
One thing is very important to understand, that whenever we are desensitizing a patient to certain drug, that is not a permanent solution. This is a temporary solution, because the patient will remain in a desensitized state for a certain period of time, and the period of time is varying for the varying drugs. It could be a few days, to it could be 1 month, to it could be at the most a few months, not beyond that. So that is important to understand. So only if we intend to use that drug in the immediate future, then only the drug needs to be desensitized and given to the patient. But after the treatment is over, and if again sometime later the patient needs the drug, then it is not that this desensitization will stay. Why? Because in cases of the drug desensitization, as Dr. Shambo has pointed out, that it is the generation 1 factor we knew in the basic desensitization protocol immunotherapy, is the generation of the suppressor T cells, which we call the generation of the regulatory T cells, and the release of the suppressor cytokines like this TGF-beta and interleukin-10. But that takes some time, and that is more of a long-lasting effect. But an immediate effect in drug desensitization, what we find is that it is the rise of the membrane threshold of the degranulating cell, that is the mast cell. So it is a mast cell membrane potential rise is one of the key factor, which is actually mediated through the drug desensitization. And this is mediated by, there are some signaling molecules on the surface of the mast cells, and they have in the cytosolic part, they have a very important and there's motif which is called the immunoreceptor tyrosine in related activation motifs. So these items are basically causes a signal transduction mechanism downstream, which increases the membrane threshold of the mast cells. So what happens is that even if there is a downstream signaling through the IgE and high affinity IgE receptor or through any other receptor on the mast cell, the mast cells are not going to degranulate because the threshold which is required for the granules to fuse with the membrane and release all the chemicals, it is much higher. And this, so what happens is that the cells goes into some sort of an inactivity or they what we call that they becomes less reactive. Okay, so the reactivity decreases, and this decrease in the reactivity of the cells, it starts from the first dose of the desensitization protocol, and it goes on increasing until the last dose of the desensitization and dose of that drug. But that usually stays for a variable period of time. So this is very important to understand that desensitization is a short-term process, and usually it starts mainly by making the cells more inert or less reactive. Nowadays, we are getting evidences of the generation of some few other cells of the lymphoid progenitor lineage, actually, which takes time and which has a role in causing the desensitization to be more active in this group. But that is all in the what is called is in its research based, and this desensitization, and it actually tested later on after the successful desensitization by a graded drug challenge to see that the patient has actually got desensitized to the particular agent, and then that drug is given for the treatment for a particular period of time.
Thank you, sir.
Some success has also been found with changing the insulin preparation.
Yes,
Also
yes,
people have done
yes,
some success in.
yes, yes, sir. This is a very interesting part. We should know that our immune system is highly specific. Okay, the allergens or the antigens which they identify is actually depends on some minute some these epitopes, and which are actually recognized by the hypervariable segment of the antibodies or the T cell receptor. So even if a minor change in the structure of the molecule, maybe the insulin, even by replacement, even by one of the amino acids, it can lead on to a conformational change in the structure, which won't be recognized by your B cell receptor, that is the IgM. The patient who was actually reacting to a particular molecule, they don't react to the other molecule, which if it is changed, and that won't be actually recognized by the immune system. So this is one. The allergic response to a particular insulin molecule by changing its molecular structure, maybe its source. Hello. Hello.
Yes, sir. We can hear you.
Yeah. Okay.
Okay, sir.
Thank you, sir. I think we have lost Nilay, sir, who was with us. We were asking some questions. Okay. We move with our next question to Professor Moitra, sir. Sir, we would like to know your view on drug-induced pulmonary disorders, how common it is, and should there be any special measures be taken for the management of drug-induced pulmonary disorders of allergic origin in specific? Over to you, sir.
See, Professor Das has here so nicely elaborated it, because we know that a drug-induced adverse reactions, it could be an immunologically mediated, it could be a non-immunological mediated. Okay. So the immunologically mediated or non-immunologically mediated, whatever the mechanism is, it can affect maybe only the skin or the mucous membrane, or it can affect any other organs. It could be kidneys, it could be heart, it could be lungs, it could be liver, or it could be GI tract, it could be any other organs could be affected. Now we know that if we are talking about the adverse drug reactions, we know that the adverse drug reactions, it could be a drug hypersensitivity reactions, or what we call and drug allergic reactions, or it could be a non-allergic reactions. If we come down specifically towards a drug allergic reactions, so drug allergic reactions, it could be limited only to the skin and the mucous membrane, or it can involve the other organs. Usually what we find in case of the severe or adverse reaction, that is SCARS, usually the systemic involvement of the other organs are there. Apart from this, there can be some other drug which can have only what is called a respiratory symptom, and the patient might have some respiratory symptoms like maybe a wheezing, shortness of breath, and cough. Or if the patient has gone into an anaphylaxis, so definitely we know that in anaphylaxis we have the multi-system involvement. The specific measure for the treatment of the drug-induced respiratory symptoms is the supportive care. That is, first of all, we should stop all the drugs and the supportive management for definitely the respiratory part. That means we have to secure the airway, we have to give the oxygen, we have to give the fluids, we can use a bronchodilators, and this is the mainstay treatment for the respiratory part. Most of the respiratory complications related to the drug adverse events, they resolve. But there are some instances where they can continue, the inflammatory process in the lungs can continue, and it can lead on to the some amount of the lung fibrosis, which could be a progressive one or limited one, and it could be a drug-induced this lung fibrosis, or it could be the drug-induced any other pulmonary complications like the hemorrhage and anything. So if it is a drug-induced interstitial lung disease, usually these patients it's a follow-up frequently to understand that how the patient is progressing. So we should not leave the patient. The patient has come out of this problem. After the patient is sent home, they should be called back after a period of 7 to 10 days to 2 weeks, where it is always important to have a complete lung function assessment. And one of the very important objective tests which we do is the 6-minute walk distance, the 6-minute walk test. Now we have the 2-chair test. These are the tests which is usually done to understand that what is the the ability, both the subjective and the objective ability of the lung for an exercise or an activity tolerance or activity endurance. Usually 6-minute walk distance, this test will be done every 6 months to understand that whether the endurance is increasing or it is remaining the same or it is decreasing. And those patients who actually show a reduction in the 6-minute walk distance by more than 20% over a period of 6 months to one year, these are the patients who are most likely going into the phase of the drug-induced interstitial lung disease. Mostly this manifests in the form of an pulmonary fibrosis. So this comes as a fibrosing interstitial lung disease in the pattern of the NSIP, or maybe in the pattern of the UIP. We don't have much medicines to treat this subgroup of this drug-induced pulmonary fibrosis. Nowadays, we have 2 important drugs which are being tried, but still they haven't come in the guideline. One is the nintedanib, another is the pirfenidone. So these are the drugs which are coming into the forefront, and maybe the nintedanib is showing some promise in the treatment of the drug-induced pulmonary fibrosis in the long run.
Dr. Moitra, some drugs are known to cause this, like say nitrofurantoin, bleomycin, methotrexate.
Yes.
Now, say for instance, somebody having a history of nitrofurantoin induced pulmonary toxicity, and then otherwise he has recovered, or he has recovered. Now, after maybe a couple of years or 3-4 years, he is required to be, because of malignancy, required to be given bleomycin. Now, is he or she is more vulnerable to suffer from bleomycin pulmonary toxicity, because they otherwise share the same mechanism?
Yes, sir. Actually, the interesting part in case of the drug-induced pulmonary fibrosis is that one thing, we have actually 3-4 factors which actually come into play while the manifestation of a drug allergy. One is the host-related factors, that is the genetics of the host and also the prior disease of the host. Next, we have the drug itself, so that is the chemical structure of the drug, and we have the pharmacological factors like the haptenization, the pharmacokinetics and the dynamics. And the fourth, what we have is the stimulation of the innate and the adaptive immunity. So what happens is that if a patient already had a
fourth factor that you have mentioned could be also the environmental factors can also actually stimulate or induce the adaptive immunity.
Yes, both the innate and adaptive immunity, which is being also tailored by the multiple environmental factors, which could be the other allergies, it could be viral infections, it could be bacterial infections, it could be pollution, air pollution. All these factors tend to have an impact on the activity of the innate and adaptive systems. So the important is that if a person who already had a nitrofurantoin induced lung injury, so this person, from the host point of view, their lung is more predisposed to suffer injuries later. But the important thing is that since bleomycin and the nitrofurantoin, they do not carry a molecular similarity in their structure. So actually, a nitrofurantoin, yes. So actually, if a immune system has recognized an nitrofurantoin and reacted to it, it is not going to cross-react with the bleomycin. So usually it is quite specific. It usually does not happen. So in that aspect, these patients are not predisposed to have a bleomycin-induced toxicity. But if the bleomycin-induced lung fibrosis occurs in this patient, then they are going to suffer more bad, since the lung is already having other fibrous components in the lungs, and since the post-vital capacity of lungs is already reduced. So per se, they are not at an increased risk of having a bleomycin toxicity, but if they develop the bleomycin-induced toxicity, they are increased risk of having a more severe disease, and they can have more serious fallout of that.
There has been some work also going on in reference to predictive medicine about this assessing the vulnerability, the genotyping.
Yes. So now we have the pharmacogenomics, which is coming up. We have this HLA typing, and by various HLAs, we can know that which individual are predisposed to which drug. Now we have, for the carbamazepine, we have some HLA types. And if this HLA variant is present in the individual, we can say that this individual is predisposed to have a carbamazepine toxicity or carbamazepine-induced adverse drug reactions. Along with carbamazepine, we have some other drugs for which the HLA markers has come out, and so it helps in actually understanding that which individuals, or if a community or a population, and based as a study of this pharmacogenomics will throw more light on which population is vulnerable to which drugs in relation to the adverse drug reactions, and which population is more immune to that drug adverse reactions for a particular drug.
Yes, sir. So can I make one comment here?
Please go ahead.
So as sir has beautifully mentioned regarding this HLA mechanism, so here is we need to emphasize one very important concept that generally known as PI concept, but actually we can also call it as a PIIR concept. That means PI means pharmacological interaction, and that IR means with immune receptors. So generally we all know about or familiar with that Hapten hypothesis, and immune response in drug hypersensitivity normally explained by that Hapten hypothesis. So we all know that it postulates drugs with molecular weight less than maybe 1000 Dalton or 500 Dalton, like that, which are very too small to cause any immune response per se. They need something like maybe a protein structure inside our body, with which it binds covalently and produce a hapten carrier complex and ultimately induce an immune response. But this PI concept, that is pharmacological interaction with immune receptors, they postulates a very important concept that drugs can directly bind with immune receptors, and that can be a non-covalently. As Sir has beautifully mentioned the importance of MHC proteins. So MHC is one of the classical examples. Just like we all know that if we can divide MHC class 1 and MHC class 2, generally MHC class 1 are mostly the cytotoxic CD8 mediated cytotoxicity they produce. And these reactions, this carbamazepine, that the Sir has taken examples of carbamazepine, which if a person has showing HLA-B specifically 1502 in Indian setting, they produce this T cell activation and produce severe types of CD8 mediated cytotoxicity and like Steven-Johnson syndrome. So similarly, the drugs like allopurinol, they have some specific HLA phenotype. Abacavir, they have some specific phenotype. So we need to understand this HLA concept so that we can predict if this drug can produce cytotoxicity, CD8 mediated cytotoxicity or not. And this is what we all know, that drug may be a chemically inert, but if they covalently bind with some proteins, in case of some excipients, they also can produce this type of serious type 4 hypersensitivity reactions like DRESS or Steven-Johnson syndrome. So this is a very important area. Sir has beautifully covered that. So this is just I want to mention.
Okay, Dr. My last question to both the panelists today. What do you think is the unmet needs in the area of drug allergy? First, we'll go back to you, Professor Saibal Moitra, sir.
The most important unmet need in the drug allergy, if you see in context of our country, is that the availability of the standardized material for testing. That is number one. Number two is that we don't know the non-irritant concentration of all the drugs, so that we cannot use all the drugs for the immediate hyperreactivity testing, even if we know that this is the mechanism. Number three is that we don't yet know the biomarkers which can actually detect or which can actually help in prognosticating the drug allergic reactions. As of now, we don't have suitable, clinically relevant, useful biomarkers to predict or to assess as the drug allergic reactions and its outcome. So these are the few very important and parameters. Second thing we know that till now we don't have a very conclusive data about the burden of the drug allergic disease in our country. Okay, though there's some data, which hospital-based data are coming up, it is being generated. We don't have any registry in our country for national registry, which is actually like assessing. Actually, it is looking after this as drug allergic reactions. Apart from that, it is very interesting to understand that, as Sir Professor Tripathi has rightly pointed out, there are some environmental factors also which is being known to actually modulate a reaction to a particular drug. As you will remember that if we talk about this environmental factor, you know how this alpha-gal allergy was found out. This alpha-gal allergy, this is a very interesting story. I'll just share this small story with you. We have time or we don't have?
We have time.
We have time.
Please go ahead.
See, actually, it was this new drug which has come up, which is the cetuximab. Okay, so the cetuximab, actually, in many patients who were actually receiving this cetuximab, it was found that there was cetuximab-induced adverse drug reaction was being reported in a particular area of the United States where the reporting was coming up to be quite high, the cetuximab-induced drug reactions, which was of the systemic drug reactions. And so means they were not sure that why it is happening and what can be the reason why the people in the other areas, they are not reporting. So they were searching for that. So there was another issue which was coming up. There was eating some kind of meat, and that meat induced that allergy was also from the registry. It was seen that from that particular area, that meat-induced allergy is quite high. So what happened is that when the epidemiologist was looking after it, they saw that these are the areas which is having a high cetuximab-induced allergy and high risk food to certain kinds of meat and all. So when they were correlating, they found out that there is a particular tick which is called a lone star tick. Okay, so this tick is quite prevalent in that particular region and of the United States. So there's a lone star tick bite reporting, the allergy to a particular drug, that is cetuximab reporting, and then this is a meat allergy of certain meat. It was all correlated to be very high in that particular region. So this prompted the investigator to look into the matter, whether there's any connection between these factors. So they just joined the dots, and then when they studied it, it was found that it's a particular molecule which is called as this is alpha-gal. Its composition is galactose 1 alpha 2 galactose something. That is the composition, and this alpha-gal, it is actually the reactivity to that alpha-gal, which is actually being formed by the bite of that lone star tick, and also it is cross-reactive with that meat. So this alpha-gal allergy, the antibodies and the T cells which are reactive to the alpha-gal, it is actually cross-reactive to the cetuximab. So when these patients were given a cetuximab, they actually reacted vigorously, having a serious adverse events and to these drugs. So these things are very important. Even if now there are a few days back, a few months back, we know that there are certain areas in the Karnataka which have this Yasnoor forest disease, so the KFD. So there was only a paper which I was reading, though that is not a very well peer-reviewed journal, but there also there's the KFD linked into it. Some drug-induced allergies was not a totally drug-induced allergy, but drug reactions, and so they were saying. But well, and I'm not saying that that is actually the fact. But usually we need to have a country-wide data, very good epidemiological data in relation to the drug allergies, in relation to the anaphylaxis, in relation to the other allergic diseases. This is a very important unmet need in our country, which should be there. It will definitely help us to go a long way in predicting a drug allergy, which is for certain drugs, and understand its pathophysiologic mechanisms.
Yes, you are very right. One part is, of course, the research gap. The other issue is about the whether we have sufficient healthcare resources to actually manage allergic disorders, because truly speaking, there is no separate discipline or sub-discipline of allergy management. There is no separate specialty, in fact. And because allergic disorders, they have multi-system manifestation, multi-organ manifestation. When it manifests with skin, dermatology, then it is in the domain of the dermatologists. When it presents with pulmonary symptoms, it is the domain of pulmonologists. But ultimately, the patient has to decide that where they can go. And there are some kind of chronic allergy, also chronic urticaria. Given the number of people who are suffering from chronic allergic disorder, there are some acute management. Yes, of course, they can go to any emergency room. But so far as chronic allergic conditions are concerned, and particularly when it can be related to drug allergy. So allergy care center, dedicated allergy care centers are also very few as compared to the people who need such care. And the very nature of disease and disease pathophysiology would also call for a multidisciplinary team, okay, for optimum care to the patients who suffer. So that is also, to a great extent, that is also lacking in our system. So these are some of the other things where, in reference to the care, healthcare delivery, in reference to allergic disorders, including the drug allergy. So where I think people from the relevant disciplines and relevant insights, they should join hands to have a collaborative team in order to better care and cater to the healthcare needs of wider people. Another gap is, I suppose, that when an allergy is diagnosed with somebody, we just tell the patient that you have allergy, and accordingly we start treating him with the whatever regimen, whatever guidelines we follow. But then whether the particular patient is also provided with some kind of written document, okay, so that when he goes to some other doctor, he can carry that document, which will actually narrate his background and his allergy condition. Okay, so that is also necessary. Whether we can think of having kind of a medication history card or drug allergy card sort of, okay, which he will be carrying or she will be carrying whenever he goes to consult any physician or any hospital, so that he gets the right kind of care. So whether this is actually practiced, I don't know. I do not come across people who are suffering from allergy. They are given a kind of summary document and advice that whenever you go to seek care to any other doctor, any other hospital, you carry this along with. Okay, so that's what I thought that we can mention here.
And one of the very important and very serious means drawback which we're still facing is that we don't have this epinephrine auto-injector available in our country. So all the patients, even if we diagnose to having a drug-induced anaphylaxis, we just don't have the option and let the patient go. Because in US and maybe in all these patients usually should have an epinephrine auto-injector with him or her all the time, which is of most importance. We recently had an anaphylaxis week. We all talk so much about anaphylaxis, but in our country, we don't have this basic thing that's an epinephrine auto-injector, which is life-saving for the patient. Any patient with a drug-induced anaphylaxis can take any drug over the counter. It is so freely, all drugs available over the counter. So they can take anything, they can have a drug-induced anaphylaxis, and they may die before reaching the hospital. So this non-availability of an epinephrine auto-injector in our country is one of the most important unmet need. Still it is.
Yeah, this is very important. This is very important. Yes.
No.
And many a times, epinephrine overdoses may be the cause of death, rather than the rather than anaphylaxis itself.
Yes.
Okay. Thank you, sir. I would invite the final comments from our chairperson, sir, before we conclude the session.
Okay, so it was a very useful evening today. Discussion we had. Unfortunately, Dr. Aratrika lost her connectivity and we could not have the privilege of listening to her. But then we have a good number of interesting questions and there was very lively discussions. Thanks to Dr. Shambo Samrat Samajdar and Dr. Saibal Moitra, and also Dr. Nilay Das. I don't know whether Dr. Das is still there, but then it was excellent inputs we received from these three erudite speakers and experts in their own fields. And a great service and great job has been done by Shatavisa as well. Shatavisa is a pharmacovigilance expert. So who could be a better person to moderate today's session, this evening session? And I suppose that I believe that a good number of people have joined and they have definitely benefited by listening to today's panel discussion. And before I hand over to Dr. Shambo, I must thank profusely all the people, the experts and the other participants who have joined for having a great success in today's panel discussion. We have 3 days gone and we have 4 more days to go. And with this, I hand over to Dr. Shambo. Thank you. Thank you all.
Thank you, sir. Thank you once again. And I just want to thank Professor Saibal Moitra, sir, Professor Nilay Das, sir, Dr. Aratrika Das, and Shatavisa Mukherjee for giving us time. And it was really a good discussion. So the last word is like that. We all know that adverse drug reactions are untoward effect, but they are often unintended. Specifically, when we are talking about drug allergy, there is a fear amongst us, that means prescriber also, that it may harm us medico-legally or by that. So we need to be more confident regarding that, and we need to report those cases. It is very important to report those cases. And as Professor Moitra sir and Tripathi sir was mentioning, we need to have some registry, and it can be a dynamic registry. And also we need some more advances in this field, specifically while diagnostics. We know how to diagnose type 1 hypersensitivity reactions, but how to diagnose type 2, type 3, that is a challenge. And yes, we have some methods, patch test for type 4 hypersensitivity reactions, but they are little bit difficult in some subset of patients. So we need one test that is very sometimes used, lymphocyte transformation test, LTT, but we need to standardize that test and we need more data on that also to have a clear-cut understanding, because that can help us to diagnose different types of hypersensitivity reactions. And also the need to search how we can manage, or if a patient has type 2, type 3 or type 4 hypersensitivity reaction to particular drug. So how we can again re-challenge those patients, because in the case of type 1 hypersensitivity reactions, we have the options like desensitization. But for other types of hypersensitivity reactions, till date, we don't have any answer how to reintroduce those drugs. So that is again a very important area we need to explore. And with that, for all practical purpose, we should follow that no blame, no shame in case of drug allergy. And that mantra all we should follow as a prescriber, because that can happen to any patient and we cannot actually predict before if a patient is going to be presented with drug allergy or not. So with that, I just again express my thanks to all of you. Tomorrow again, we have another session on this series of lectures. Tomorrow we will discuss about patient safety in considering the elderly populations. And for that, we have one expert from clinical pharmacology subject, that is Dr. Shaugato Sarkar. He will deliver a lecture from 8:30 p.m. I request all of you to join us and to enrich us with your expert comments and active participation. So with that, again, I want to thank all of you. May I request Mr. Rohan Tripathi to have some final comment, and so that we can conclude our meetings tonight. Good night, all.
Thank you so
Good
much,
night.
Dr.
Good night.
Samajdar. It was indeed an honor listening to all our distinguished experts, Dr. Moitra, Dr. Das, Dr. Samajdar, Dr. Tripathi. And it was a great session that was very skillfully moderated by Shatavisa Mukherjee. And it's very unfair to, after so much of informative discussion, to stand in between you and your dinners. So I would like to welcome you all tomorrow, so that we can be a part of another such informative session from 8:30 p.m. sharp, and for 4 more days to come, so that this entire week is as successful as today and the last 2 days were. So with that, I thank you everyone from the bottom of my heart, because without all your time, your effort, these sessions would never have been successful. So thank you all. Thank also our participants who have been there with us, even after we have pushed over half an hour of the scheduled time. But I guess with the speakers that we have, it's only fair that we do so in order to give everyone the chance to speak. With that, I won't eat up any more time and say good night. Hope to see you all tomorrow.
One thing we just forget that I want to again re-emphasize, though before we already mentioned that this event, this panel discussion was collaborated with Allergy Asthma Research Center, and we are really thankful to them, Allergy Asthma and Asthma Research Center. We have Professor Santanu Tripathi and Dr. Saibal Moitra sir, who are a part of that esteemed institution. And I think Dr. Jayati Das also had joined our meeting today. So we are really thankful to them also for extending their support. So thank you Allergy and Asthma Research Center also.
Thank you very much.
Thank you.
Thank you.
Good night, everybody.
Good night.
Okay.
Thank you.
Good night.